Well, hello, and welcome to the discussion on the cerebrovascular disease and acquired neurocognitive disorders. So this is a continuation of Kendall Appendix C, which is the last section that speaks about what happens when some blood vessels in the brain malfunction, and what kind of problems and what kind of disorders do we get based on the territory for particular arteries in the brain. So first, let's speak about stroke, and then we'll go to other things that could happen. A stroke is a cerebrovascular accident that takes place in the brain because of one of two things. Number one, either a blockage of an artery or a rupturing of an artery in the brain. So the first kind, the blockage kind, we call it the occlusive strokes. And this is caused by any occlusion, something that blocks a blood vessel. Just imagine, look at the blood vessels, examine the structure. We go back to the section where we speak about the territories for blood vessels in the brain. You notice that blood vessels begin like branches of a tree. They begin large. As they branch out, they branch into smaller and narrower branches, just like a tree. So that means, for example, if there's a blockage in one big artery, it is going to affect the many branches above it. In the meantime, if there's some kind of plaque, say for example in a major artery, and the piece of that plaque is dislodged because of the blood pressure, that means that it is only a matter of time when this tiny piece of plaque, or maybe blood clot, finds its way as it travels to smaller and smaller and smaller and smaller arteries. It is going to find one eventually that is smaller than it, so that it's going to be lodged into the diameter, into that little artery, and it will block it, and it will prevent blood from flowing into it. And as a result, the entire area that is supplied by this kind of blood vessel is going to start to infarct. And we'll speak about infarction and what it exactly means. So the first kind, again, is occlusive, which results from blockage of a blood vessel by either a blood clot or a piece of plaque that gets dislodged from an atherosclerosis sclerotic artery. And the other kind is hemorrhagic. So the hemorrhagic stroke results when a blood vessel ruptures because of high blood pressure. There are some blood vessels that cannot take the pounding of a lot of blood through them, and when someone has higher blood pressure, basically they have more blood in their body, so that is going to keep beating and beating at the walls of the arteries. And in some cases, at the very small, when they are very tiny blood vessels, arterioles at the very end, they have very tiny membranes, very small membranes. And if the blood pressure is particularly high, it increases the risk, someone's risk, of one of these vessels just rupturing. And another way is if there's an aneurysm. An aneurysm is some kind of it results from a weakened spot on a blood vessel, where that spot because it's weak and the blood is going through, it is pushed out and it's made into a little balloon. And that little balloon is going to begin to grow and grow and grow. And at some point, of course, the more it grows, the thinner that is going to be, like a balloon. When you blow the balloon, the wall of it becomes thinner and thinner and thinner until it can't take the pressure anymore and it's going to erupt. So aneurysms are something that people are born with, and they mostly they are born with these, and they continue to grow, and when they reach at some point to be bigger, then they are discovered by certain symptoms, headaches and something like that. And if they are not discovered, then they rupture. They are going to cause leak inside of the, the brain, between the skull and the brain. And that when you have now blood loose there, number one, it has toxicity inside of the blood. There are materials that you cannot expose neural tissue to, because it could be toxic. In addition, it is going to put pressure on the parts of the brain that are close to that rupture, and it will continue to widen. So if it is severe, if it's a major artery that is ruptured, it continues to push down on tissue of the brain. And somehow, because the brain is housed in the skull, you could look at the base of the skull here, and you could see that it's almost like a funnel shape. And when there's pressure above, it's going to push down, so that the pressure goes through the base of the brain stem, and then the spinal cord. So that is going to cause herniation. It's like having toothpaste and squeezing it out of the tube. So herniation it results when the pressure from the blood continues to push down on brain tissue to displace it out of its normal place, and to push down whole sections of the brain. And gradually, if that increases, it is gonna cause death. So that is what happens when there is a hemorrhagic stroke. Again, it erupts occurs because of an eruption of a blood vessel, or an aneurysm. This is an aneurysm, like a little ballooning part of the wall of the artery that is due to weakness of the wall of the artery. Of course, that is abnormality, and there are particular areas that are known to have a higher risk for developing them. You can see here on the left, there is a hemorrhage now happening here, and it's going to cause damage in this area. It will push down on the tissue. It will shear a lot of axons, and at the same time, it is going to cause toxicity to some tissue there. So, but the damage, if it's a major blood vessel, it could lead to death. The person has to be rushed very, very, very quickly to the hospital. The occlusion part, when the blood clot or a piece of plaque blocks the artery, then the entire area, as you could see, becomes deprived of oxygen and glucose, and the whole area that is supplied by the brain doesn't get its nutrition, especially oxygen, and without that it cannot survive. So there are limits in time, and when you look at an area like this, there's a center, usually a center that has dead tissue. That is, this whole area here is ischemia, and it has an area of dead tissue surrounded by an area called the penumbra that has some tissue around, that is not dead yet, but it has lower supply, a decreased blood supply. And if the problem is not resolved immediately, quickly, that area of the penumbra is going to turn into an infarction. Basically, an infarction is dead tissue in the brain. So, atherosclerosis is a disease of the blood vessels, and it results when the inside of the blood vessel accumulates a lot, plaque and fibrins and different things from the blood, build up and build up and build up, and basically the entire circumference of the blood vessel is sometimes surrounded with that layer of plaque, and it makes the vessel less, and it makes it unable to dilate and to constrict. The blood vessels have that ability that is regulated by the autonomic nervous system that enables the blood vessel to dilate and to constrict based on the level of the gases in the bloodstream and based on the needs of the body, including the brain, of course. So the atherosclerosis, as you see, it is not even, and eventually it will block the entire blood, the entire artery. There are some occasions when some of the pieces of the plaque get dislodged, or even the site might promote a blood clot. But this, when a piece of plaque is hanging down from the atherosclerotic site, it's hanging down, it is not dislodged yet. It is called the thrombus. Sometimes you say thrombotic stroke, a thrombus caused by a piece of plaque that gets loose. When that piece is broken free, as you see in the image, we call it an embolus. So from a thrombus, it turns into an embolus. An embolus is a ball freely floating in the bloodstream, and until it keeps going up because the blood pressure is pushing the blood up, until it reaches a small artery that it cannot pass through. And as it reaches, from bigger areas to smaller areas, suddenly it just gets jammed in with force, and it plugs that entire little, artery, and the whole area now starts to go into an ischemic area where there is deprivation of oxygen and deprivation of glucose and other nutrients. And as I mentioned, if that ischemia or ischemic site is not immediately resolved, if the blockage is not immediately resolved, then the area is going to turn into an infarction, which means death of the neural tissue that is supplied by this area. So an ischemia or ischemia is insufficient blood supply, and it causes anoxia or lack of oxygen deprivation, and also glucose deprivation. So that is one major side effect, that the brain areas hit by that do not get the nutrition that they need in order to survive. And keep in mind, brain tissue cannot survive more than a few minutes because the brain does not store nutrition. It doesn't store oxygen or so about 6 minutes is just about the biggest cells, pyramidal cells. They can survive for about maybe 6 minutes or so. So one big major effect of ischemia or insufficient blood supply is anoxia. The second one is the inability of the brain tissue in that location to remove metabolic waste. So it is two things. I mean, you have to keep cleaning up the waste and at the same time getting the nutrition, but in that case, you cannot do either in a case when there's ischemia. And then if that ischemia is brief, if it's not severe, the damage is limited, then that could be, the effects could be reversed. However, if it is prolonged and severe, the ischemia will cause infarction or cell death or death of the nerve tissue in the area that is supplied by that blocked blood vessel. When the area, the infarction occurs, again, there is a center of the dead tissue, and around it, there's ischemic tissue that, in the periphery that hasn't died yet, but it doesn't have enough oxygen yet, and nutrition. So if the help is provided immediately and the blockage is resolved, then that tissue could be salvaged. And that is the goal of medications that seek to melt the clot or the piece of plaque. So for a hemorrhage, again, as I mentioned, it results from either rupturing of an aneurysm or rupturing of a blood vessel because of hypertension. A hemorrhage could cause a blood clot, and that, if that is the case, it is the blood clot that results is known as a hematoma. So, and that hematoma will be within the cerebral hemispheres, and also it could be in the brainstem or in the cerebellum. So again, blood clot caused by hemorrhage is known as a hematoma, and it can exist in one of the hemispheres, or it can be in the brainstem or the cerebellum. The hemorrhage could also cause an ischemia or an infarction because, as you could see, for example, maybe in here, there will be an area of dead tissue there because the pressure, number one, and the exposing the neurons and the neuroglia to blood substances in the blood immediately, that is going to cause toxicity, neurotoxicity. At the same time, the pressure that is being put by the blood that is there pooling and accumulating and increasing, that is going to cause shearing of axons and pushing axons and neural cells away from where they naturally are. So that is going to cause cell death, infarction. So here you could see, in terms of the ischemic or ischemic stroke, you could see now the blockage because of atherosclerosis, and then you have a center where there's an infarction, dead tissue, surrounded by, and that area, that tissue is called umbra, and the area around it is called penumbra, or the area surrounding the infarction. So, and that is the area that medication serves to salvage if you get the person within a few hours quickly enough to the emergency, and they have the blood thinner and the medication to melt the clot or the plaque. That is going to most likely it's going to salvage the area around the umbra. One major effect of strokes is that they alter the physiology of the brain. How do they do that? Number one, the blood vessels in the brain they raise pressure and lower it based on the level of gases and based on the need of the nutritional needs of the brain. So the wall of the blood vessel is supplied by nerves, so the nerve tissue, to make it dilate or to make it constrict. When you constrict, you are going to raise pressure. So it's like a hose. When you have a hose and narrow the opening of the hose, the water shoots far away. And as a result, your head is up and you want to bring the blood from the heart, so you constantly are pushing blood up. So this way, the autonomic nervous system regulates blood vessel activity, dilation, and constriction, and it's an automatic process. However, when stroke occurs, that causes something called vasomotor paralysis, from blood vessels and motor movement. So the blood vessels are unable to constrict to raise pressure. So that causes hypotonia, or weakness of blood vessel ability to constrict. So this hypotonia is caused by the blockage of the activity, basically, and the nerves that stimulate the vascular constriction. So because that whole area, these nerve branches are now unable to function because of the infarction. They are dead. So that could lead to death of further brain tissue in the penumbra if that issue is not resolved. The tissue in the penumbra could be dead if it goes beyond a certain number of hours. So the medications typically given for a stroke include cerebral vasodilators, which dilate the blood vessels, for example. And one of the side effects of these medications is an increase in cerebral blood flow in areas that are distant from the area that you want to treat. So that, in effect, is going to take away blood from the site where you need blood in. So that is one of the side effects. For the medications that degrade the embolus or the blood clot, one major goal, the primary goal for these, is to melt that and open the site, the blood vessels, so that the blood can go through and bring in oxygen and bring glucose and other nutrients. So this way, it targets the tissue in the penumbra that hasn't died yet. Looking at now what happens if something in the territory of the anterior cerebral artery goes wrong, if there's an infarction there. First, we'll consider the unilateral infarction. Unilateral means on one side. So if it's on one side, it causes weakness and sensory loss, mainly in the opposite side, in the contralateral leg. And remember, anterior cerebral artery. This is the anterior cerebral artery here. Okay, and then the other part is the middle. So that is the area we're speaking about. This is the part of the territory of the anterior cerebral artery. So damage there is going to cause weakness and sensory loss mainly in the opposite leg, in the contralateral leg. Because right brain controls left side, and left hemisphere controls right side of the body. Damage to the supplementary motor area. Remember, the supplementary motor area is an area that's in front of the primary motor cortex. So if the primary motor cortex is like my finger here, supplementary motor area will be here, and it will be in between the hemispheres. Let me show you what it looks like on the brain. So here is the primary motor cortex here, and in front of it, in this location, that is the supplementary motor area, and it starts here, and it continues in between the hemispheres. So it is this location here. That is part, so it starts on the top, and then it goes in between the two hemispheres. And that area is very important for speech planning and the initiation of motor movements for speech. And as a result, if that area is damaged, it is going to cause speech abnormalities in the production of speech. Damage to the anterior corpus callosum. Recall that parts of the anterior cerebral artery supply the anterior corpus callosum. So damage in that area causes apraxia of the left arm. Apraxia is inability to direct your some kind of, an organ, whether that's the tongue or the hand or whatever, to direct it to do what you want it to do. Even though you know what you want, it is not doing what you want it to do. So, for example, point to your nose. You just go this way, that way, this way, and you might finally go, oh, my nose here. So the person just goes around and tries to find, and then they might get it, they might not. So then, this is called sympathetic apraxia. It is in the left arm, and it results from disconnection of the left hemisphere from the right motor cortex. Remember, we are speaking about the corpus callosum that connects the two hemispheres. So if you have that piece basically having no nutrition, it's damaged, then the person is going to have the left hemisphere, they are going to have left arm apraxia. That is again because the left hemisphere is disconnected from the right motor cortex. This is again a region of the anterior cerebral artery. This is the middle cerebral artery. This is the posterior cerebral artery, and you could see from the sagittal view, you could see the area of the anterior cerebral artery. Basically, the entire frontal lobe is supplied by it. You could see the anterior corpus callosum also supplied by that. And you could see here the two sides. These are the two sides of the artery. And so bilateral damage to the anterior cerebral artery, you are speaking about the two sides, causes abulia, which is severe behavioral disturbance consisting of profound apathy, motor inertia, and muteness. So I mean, the abulia, having apathy. Apathy is lack of interest, enthusiasm, or concern. The person just basically they look like they absolutely have no motivation to care at all. So that is one diagnostic feature. The other one is motor inertia, that they just don't want to be activated to do much. They kind of they don't want to be active. Muteness, and that is remember, bilateral, two sides. So you have extensive damage here. And that is due to the destruction of the inferior frontal lobes, the orbitofrontal cortex, and the deep limbic structures, which include the basal ganglia and then the supplementary motor cortices, both of them, and the cingulate gyri. All of these are critical for planning speech and for producing speech. And if they are destroyed, then the person will go mute. The left posterior cerebral artery, as you can see, it supplies the inferior half of the temporal cortex, all the occipital lobe or cortex, and the big piece of the parietal cortex. So you have vision, hearing, memory, and you have sensory mechanisms. So here, one big problem the person will have, and we're speaking about the left posterior cerebral artery infarcts. We are limiting this to communication and swallowing. So there are other neurocognitive and motor problems, but because they don't relate as much to speech, we just focus on the communication and swallowing component. So alexia, or the inability to read, results from left posterior cerebral artery infarction. And the person in that case will not have aphasia, and the person will not have difficulty with writing. They just cannot read. And the reason is that the right occipital cortex, right occipital cortex is disconnected from the language centers of the left hemisphere. So as a result, the person cannot integrate. They cannot read. And then, if the damage is bilateral in the posterior cerebral artery, if the infarction is bilateral, that sometimes occurs at, on the level of the basilar artery. When let me show you an image. Here is the basilar artery. When the two vertebral arteries unite into the basilar. So we're speaking about a major, massive, branch that is going to cause significant damage. So if it is bilateral, on the level of the basilar artery, that causes cortical blindness, a syndrome known as Anton syndrome, and memory disturbance, and that is because of the bilateral damage to the inferomedial temporal lobes, because as you could see here, because of the damage in this area. So Anton syndrome, or cortical blindness, that's a very kind of strange kind of disease where the person is blind, but the person doesn't think that he or she is blind. They insist that they actually see. And that is because the visual cortex just projects images and things, and they just, basically see these images, and they think they are real and that they reflect the reality they see around. However, they just fall against furniture and they can't find their way. So Anton syndrome. Then anterior choroidal and penetrating artery infarcts. These result from occlusion to the small penetrating arteries that arise from the circle of Willis, for example. The circle of Willis, remember, is an area that unites, that connects all the blood vessels in the brain, and it is, the saying goes that no one has a perfect circle of Willis. and some people are missing certain branches, some people are missing certain connections. So occlusion on the small penetrating arteries that arise from the circle of Willis or proximal portions of the middle, anterior, and posterior cerebral arteries causes lacunes. Lacunes are small infarcts, like local but very small infarcts, but sometimes there are several of them. So if these little lacunes are bilateral on both sides, and if there are so many of them, that is going to cause progressive dementia. Progressive dementia and shuffling gait, similar almost like to shuffling gait. The person has difficulty lifting up their feet and moving. Also pseudobulbar palsy. That is a spastic dysarthria, in addition to dysphagia, in addition to lingual and pharyngeal paralysis, and hyperactive palate and gag reflexes. So in addition, they also have emotional lability, that the person easily cries and easily laughs, and their crying and laughter are exaggerated beyond the context, beyond what the context basically allows for. Sometimes they switch from laughing to crying directly with no reason, with no cause, or from crying to laughing with no cause. And that is part of pseudobulbar palsy. And that is basically because of the pathway that goes from the cerebral cortex to the brain stem. That pathway used to be called the pseudobulbar tract, and it has a new name now. Anterior choroidal and penetrating artery infarcts. If the infarction is restricted to the recurrent artery of Hübner or other deep branches of the anterior cerebral artery, we are speaking about the penetrating branches. There are superficial ones and there are some penetrating ones. So if that infarction is restricted to the recurrent artery of Hübner, so if the infarction occurs in these deep penetrating arteries or the recurrent artery of Hübner, that will cause dysarthria and contralateral neglect. So neglect on the other side, it means that the person will have weakness and they would not, in some cases, they wouldn't be able to see parts of the periphery and the peripheral vision. So if it's in the right and the left hemisphere, that will cause language disturbance because the left hemisphere is dominant for language, as we know. Now, when we speak about brain stem and cerebellar infarcts, many of these, as your textbook shows, are deadly. So we're speaking now about the ones that aren't deadly and produce language and other problems, swallowing and so on, problems. So if the occlusion, for example, the occlusion of the vertebral artery, or for example, sometimes, even though it is not as frequent, sometimes the posterior inferior cerebellar artery, if there's an occlusion there, that causes an infarction of the lateral medulla. Let's go here and look. So here is the medulla, and above it is the pons, and we are speaking about the vertebral artery. You could see it's on one side of the medulla, and out of that there's also the posterior inferior cerebral artery here. So these are both on the lateral sides of the medulla. the medial or the paramedian is in the middle here that we're going to speak about later. So if there is damage to the vertebral artery or the posterior inferior cerebellar artery, that is going to cause, again, infarction, damage in the lateral medulla. And the results will include motor problems, sensory problems, communication and swallowing problems. These include dysphagia, hoarseness. But why is the dysphagia? Remember, swallowing is a primitive function, and the brainstem plays a tremendous role in it. Hoarseness, because there are nerves, cranial nerves, and among them is the vagus nerve, for example, that supplies or innervates the vocal folds. So that is the result. If there's damage in the sides, it will affect roots of some cranial nerves that enable us to do certain things. And then ipsilateral weakness of the palate and vocal folds. Ipsilateral means damage on the same sides. On the same side as the infarction is here, you have the damage on the same side. So ipsilateral weakness of the palate and the vocal folds. And also ipsilaterally decreased gag reflex because of the structure called the nucleus ambiguous, or the glossopharyngeal ambiguous nerve outflow tracts. These are affected, and as a result, the person will have gag reflex, decreased gag reflex. If the infarction is in the medial portion of the medulla, let me go back again here, in the medial portion of the medulla here, what's going to happen? We have contralateral hemiparesis, weakness on one side, and ipsilateral tongue weakness on the same side as the lesion, as the infarction. With also dysarthria and deviation, the tongue is going to deviate toward the side that has the hemiparesis. Let's say, for example, as I'm looking now, this is the side that has the hemiparesis because it is being stretched out. This one is contracted. So the tongue is going to be deviating toward the side that has the hemiparesis. And look, the cue again is ipsilateral. So the tongue is going to be damaged in the same side as the infarction. So if I'm going like that, the infarction will be here, affecting the weakness here, and then the tongue is going to be strong here. The tongue is going to be, the weakness of the tongue will be on this side. So, and then contralateral impairment of proprioception and discriminative sensation. Proprioception is the sensation, sometimes called the sixth sense, the sensation that we get from our joints and our muscles about how they are adjusting in space, how they are moving, what direction they are moving, and whatever is going on, we feel that proprioceptive feedback, and we adjust our movement and our posture accordingly. So that is going to be impaired, and the person will have difficulty feeling their body in space and the organs of the body as moving. So, but the damage will be contralateral. If the infarction occurs in the caudal segment of the pons, we are going up from the medulla oblongata, going up to the lower segment, or what we know as the caudal segment of the pons. As you could see now, we are going from the two vertebral arteries, they are uniting as they go on the surface of the pons, and then we'll see what happens. So the caudal segment of the pons, if there's an infarction there, that's going to cause contralateral facial weakness on the opposite side, and contralateral impairment of proprioception again. And then we have palatal myoclonus, and that's a disorder that is a motor disorder characterized by rapid involuntary movements of the palate and the pharynx and the larynx and face and eyes and respiratory muscles. These muscles are just, they move involuntarily, like twitching, and the person will produce certain voices and clicking sounds with the larynx and the pharynx and the palate. What if the lesion is bilateral? If someone has bilateral brainstem lesions on both sides. So again, as your text, states, the results could be devastating, and depends on the severity and so on. If there's a paramedian infarction towards the middle of the upper brain stem, that can destroy the reticular activating system that controls your arousal and your alertness levels, and it would cause stupor or coma. So coma, you know what it is. But stupor is a very, very deep state of unconsciousness where the person is like sleeping and sleeping and sleeping, and you can't rouse them. So when someone might transition from stupor to coma, so it is very, very close to a coma. And then a bilateral infarction of the rostral basis pontis destroys this rostral basis pontis is, if you look here, you'll find it is part of the pons, and sorry, I can't enlarge the image, but if you look here in the middle, and in this little area here, this says basis pontis, part of the pons. We speak about the rostral, about the anterior segment of it, and the anterior superior segment of it. So in that location, if there's damage here, that is going to cause to destroy the descending corticospinal tract and the corticobulbar fibers as well. These are very, very major motor highways. That causes paralysis of all muscles except eye movements, and that causes the syndrome that is known as locked-in syndrome. That the person cannot move any muscles except the eyes, basically, to be able to. They can communicate with the eyes. They are conscious usually, and they cannot do anything other than just moving their eyes, and they can communicate with the eyes. So that is the end of this section. As I mentioned, I wanted to make the videos shorter. So the next segment is going to speak about aphasias and the major kinds. So thank you, and I hope you have taken good notes and that you come to class with the questions, because if you don't have questions for me, I definitely will have questions for you. Thank you.